Good afternoon. As I began to research this topic, I was struck by the power of the human body and the power of the interface between mind, body, spirit. Uh, for instance, the human body can fight infection. It can heal broken bones. It stores fat for future mobilization of energy. It mobilizes energy for fight or flight. For these systems to function well, we need nutrition, a sense of well-being, and adequate sleep, among other things. It is my belief that treatment of any medical illness is not complete without consideration of psychological factors and a treatment approach that includes awareness and treatment of all underlying conditions. I want to take a look at hypertension and the psychological factors associated with hypertension. Most of us have heard about type A personality and a high correlation with coronary artery disease and heart attacks and death. Type A personalities are very competitive, intense, driven individuals who are task focused and intense in their work as well as in their play. This intensity has an effect upon the rate of development of cardiac disease and most likely other diseases as well. I believe this occurs through affecting the neurological, hormonal pathways in the body. Successful treatment can only occur and by lowering the risk of future heart attacks by including psychological as well as medical attention. What does this have to do with hypertension? With any illness, I think it's important to look at the total milieu or environment of a person's life. For African Americans, it's impossible to separate the effects of living in this so-called post-slave culture from our life experiences. I think about cooking soup. I've got all the ingredients to make a great soup. I love vegetable soup. I have all my vegetables, my broth, my liquids, and I decide to raise the temperature on the soup. This changes the outcome. Different ingredients break down at different rates, but it all mixes together for the outcome. I think likewise, living in a hostile environment places one's body on high alert. Our body's neurochemistry is basically at an alert state, telling us to look out for danger. This raises our cortisol levels, raises the intensity of our responses, raises our catecholamines for a quick response, and raises the blood pressure. This has to have an effect on long-standing blood pressure problems, which lead to higher rates of strokes, higher rates of heart disease, and shortens our lifespan. I'd like to share a small vignette of a former patient. EB was a 46-year-old African-American female who presented to the psychiatric clinic with post-traumatic stress disorder. She remained in treatment with me for 2 years until I left that particular facility, and she was unable to follow me to my new clinic. She had survived a severe automobile accident in which her husband died. Who at the time that she presented, it was about 2 years from the accident. She had severe injuries for which she had healed. She was still mourning the death of her husband and still had visions and flashbacks and difficulty with sleep related to the accident. During the sessions, she screamed, she wailed, she cried, she relived the trauma basically in my office. And the office was a very small office with multiple offices adjacent to each other. The soundproofing wasn't very well, and her cries could be heard all over that floor. During that 2-year period, we did form a positive alliance, but she was never able to move past that trauma. Most days not able to get through a session without recapitulating the whole scene. I did transfer her care to another psychiatrist when I left. Unfortunately, I received a phone call from her daughter 3 years subsequently, with the daughter telling me that my patient, her mother, had a stroke during one of the sessions and subsequently died. Why am I bringing up this sad situation? For one thing, it touched my heart. For another, in looking back, although at the time my work with her and the team felt that we were making headway and it was a success, we still lost the patient. As I look back, and I don't have access to a record, so this is all memory, I don't recall whether we had that comprehensive approach. I don't recall if I had access to her medical records. At that time, I know we were not checking blood pressures in the clinic. And, I know we did not collaborate her treatment with her medical doctor. The focus of the treatment was the trauma, her ongoing grief, her anger at her husband for dying, her anger at him for taking that trip without properly looking into the repairs the car needed. This was some of the soup that she was dealing with. But in the larger sense, I don't know what other issues she was facing. She was an African-American woman. She had 2 children. Her children had gone to public school and were doing well. In fact, that particular trip, they were on their way to Texas to their daughter's graduation from college, the first person to graduate from that family. What I do know, they had financial problems because her husband was not able to afford, or felt he could not afford at the time, putting the car in the shop before they left. I don't know what the chronic stresses were leading up to that point. I don't know how being an African American female in New Orleans affected her. I don't know the degree of poverty and day-to-day stress. I don't know what her diet was. She was overweight, but I don't know the other nutritional needs. All of these issues play a part in us being able to adequately treat her and other people. Just as an aside, I was seeing her through LSU, Louisiana State University, and that did allow her to get more attention, actually, than most patients would receive. I saw her 45 minutes each session every week. At the same time, the mental health clinics, that treatment would have involved seeing a psychiatrist maybe once a month, but that once a month most likely would have been a medication check in a group setting where 10 patients were seen at the same time, and you go around the room and check and see how each person's medication was working. It would also include meeting with the social worker, possibly once a month, but again in a group setting. I was not able to adequately meet her needs through 45 minutes a week, four times a month. The mental health system woefully would not have been able to meet those needs. This is the system in which we attempt to provide treatment. It's not comprehensive. The mental health clinics, when they were first instituted in the 50s into the early 70s, were more comprehensive, and may have even included psychoanalysis, medication management, what I call real therapy, in terms of meeting weekly, or sometimes more than once a week, with a whole team approach. Probably not the medical part, but a whole team approach from the psychiatric needs. Since that time, that system was slowly dismantled, along with decreasing hospitalization availability, along with emptying the long-term psychiatric institutions, which has played a part in the current homeless crisis this country faces. And what's been driving this is so-called economics, in that it was not profitable. Although, the system won't say that. What the system will say is medications have evolved, and medications are more effective. And that is partially true, but at the same time, the type of availability of care has been squeezed and squeezed and squeezed till it's not adequate. You know, and when I think about the needs of people, but particularly our focus is on the needs of the African American population. Living in this post-slave environment affects every African American, including myself, which places stresses upon the body that lead to, as Dr. Gibbs related, the higher incidence of many diseases, higher psychiatric needs, psychological issues, and extremely limited availability of care. Even when the availability is there, it's frequently inadequate. So, you know, we as a people, Dr. Gibbs talked about the empowerment. We as a people do need to address all of these issues, where at the same time as learning to self-empower. Just a short example of how a minor example. This is minor in some ways. How I am affected by living in this post-slave environment. When a policeman pulls up behind me, my first response is intense. Then my rational self kind of takes a check. Well, I didn't do anything illegal. I'm traveling the speed limit. You know, maybe I get pulled over for something. And so then my veneer of calmness and so-called rationality takes over. But that first response, that internal, intense crisis, it's done something to my body. And you know, and think about this occurring many times in your lifetime, sometimes many times in a day. It takes its toll. No wonder there is a higher incidence of many illnesses. But getting back to hypertension, there is a higher incidence of hypertension in many psychiatric conditions: bipolar, depression, anxiety, schizophrenia. And this leads many people to ask the question, does the mental illness cause the hypertension, or does the hypertension cause the mental illness? Insofar as depression, it has been shown that this is a bidirectional phenomenon, meaning that hypertension can drive development of depression, and depression can drive development of hypertension. This makes sense when you realize that both conditions affect our neurohormonal environment. I'm almost like a circuit board. The implications for treatment then means whether the depression came first or the hypertension came first, one can't be treated without treating the other. And that treatment may include medication, nutritional, behavioral, and as well as a psychological focus. Similar dynamics exist between obesity and mental illness. Again, there's a bidirectional relationship between depression and obesity. With depression, there's a decrease in feelings of well-being, a decrease in energy, a decrease in sleep, and possibly an increase in appetite, all of which can lead to weight gain and to the development of a metabolic syndrome. Likewise, obesity can play a role in development of depression. Obesity can lead to development of sleep apnea, in which the body's sleep needs are woefully diminished. It can lead to development of a metabolic syndrome, low energy, low self-esteem, a sense of hopelessness about achievements, and all of this then can lead to a depression. Looking at this as bidirectional is probably too simplified. I think it's more likely circular, with many neurohormonal factors coming into play, like a circuit board. One malfunction can be bypassed, but on that circuit board, when there are multiple malfunction points, you've got a massive breakdown and a holy mess. And it's no wonder so many treatments fail. It's because we approach things narrowly, attacking one part of the system. Have you ever heard someone say, all I have to do is smell food and gain weight? What they're saying is that there's so many malfunctions in my neurohormonal system that is driving my weight gain, even with the tiniest of changes. And I believe that. Changing one part of the circuit board may drive positive results, but only most likely lead to short-term results. Depending on the severity of whether it's hypertension or obesity, depending on the severity, it may require throwing everything you have towards the problem, including the kitchen sink. This means repairing as many parts of the circuit board as possible. Repair sleep problems, improve diabetes, improve hypertension, focus on improving mood or depression problems, address grief issues, address sociological issues that keep an extreme high stress situation. It may involve diet pills. It may involve weight loss surgery, psychotherapy, and referral to a spiritual therapist. Changing one part of the system can drive to improvement in the rest of the system. Changing many parts of the system improve the chances for improvement. Sometimes changing one thing can override many other things. For example, focusing on an intense weight loss program with some success can lead to improvement in self-esteem, improvement in a sense of self-power, and mobilize the power of the body to heal itself. You've heard the term, you are what you eat. I believe that's true. But you also are what you think, you're what you believe, and you are what soup you are boiling in. Uh, we have to address all of them to improve our health. And lastly, you've heard of someone who said, I woke up one morning and said to myself, no more crack cocaine. I woke up one morning and said to myself, no more cigarettes, no more heroin, no more methadone. I don't know about no more Oreos though. That conviction has led to an overnight or instantaneous change in the underlying problem. And this speaks to multiple factors in that person's life that has led them to, whether it's to feel self-disgust, whether it's to draw upon everything within themselves, whether it's to draw upon a history of spirituality that allows them to really say no more, and it's no more. Most of us need the kitchen sink. And that kitchen sink is a biological, psychological, sociological, and spiritual treatment plan. And the sooner we are able to provide that, I think we stand a chance of changing that collective history we talked about in the past, where there's actual changes in our DNA that propel us towards disease and unhealth. So I'll be happy to entertain any questions.